We focus on diabetic nephropathy, on retinopathy, and on cardiovascular disease complications in type 1 and type 2 diabetic patients. And we divided the program in 3 phases. The first one we call the discovery phase. We try to discover on existing biosamples, novel genetic and also biomarkers for these diabetic complications. Then we start the validation phase. What we have discovered in the discovery phase in the first 18 months will be validated in other cohorts in order to predict in those cohorts that our discovery was exactly right. And the third phase, in the years 4 and 5 of the consortium, we will try to translate these findings into clinically relevant settings. That means we start new clinical trials and involve these biomarkers, genetic markers, and also the imaging modalities in order really to translate that in a real life setting. This sounds complicated, and it is complicated, and therefore you need a consortium. And we have, as also the other consortia, divided our consortia in different work packages, which are led both by an academia work package leader and a work package leader from the FPR. But all these work packages are very closely interrelated. They use the same clinical samples. It makes no sense to do genetics on the one sample and biomarker on the other one, but we use the same sample for imaging, for biomarker, and for genetics to have really a good outcome and a good result, a meaningful result of that. And on top of that, as I mentioned, we are also taking care of animal models in order to help further research in that area. And these animal models also try to cope with the findings of our discovery phase in the clinical setting, and vice versa. Findings from the animal model work should also be reflected later on then in the validation and in the translation phase in our clinical trials. On top of that, we are trying the data mining and in silico modeling. What do we expect is the benefit for the patient? The benefit is twofold. Number one, we want to identify early on patients at risk of developing diabetic complications. As I said before, despite the fact that people have the same hyperglycemia, the same bad glucose control, the one develops a complication and the other does not, or the one does it more rapidly and the other develops it only after a decade or even longer time. So we want to have and want to identify, want to define the patient's risk for that. And then also we want to help a faster development of compounds and drugs targeted on prevention and treatment of diabetic complications. And that in the future will help, of course, our patient. That's the twofold benefit to that. On top of the patient benefit, we have also the added value of the consortium itself. I think, as I mentioned before, you can do such an enterprise only in a large consortium. You have to join forces. And you can only do that in a consortium with a funding and with a longer duration, like the summit in 5 years. Then you can really gather the world-class experts to really provide their capacities and their expertise into such. A consortium also offers a broad access to biobanks. You can't do it with one academic center. You need more. You need also more cohorts and not only focused on one territory or one ethnic background. You should have a multifaceted approach. We also combine the expertise to overcome the bottlenecks in the research area. Think about these very complicated imaging technologies. Think about the variety and the number of potentially available animal models. And we should do that as a multifaceted approach. We use the consortium also to foster the interrelationship between academia and the FPR partners and try to work out and find out the synergies between the different approaches and partners. What we have experienced so far in the last 9 months to 1 year is also, I think there is a new spirit in working together between academia and FPR partners. there is more trust, and that trust is, I think, growing every day, and you can really see that and feel it when we have face-to-face meetings, when we have telephone conferences within the consortium. This is an openness which I never experienced so far, and I think the consortium itself helped a lot. And that goes to the benefit to all of the partners in the consortium. The academic partners, they benefit clearly from their intensified networking within the academia, which they somehow experience in other consortia, of course, but this is really a larger consortium where they can really network across countries, across also different technologies, which they have not done before. The FPR partners is also, as I said, a new experience to work not only with one university group, but also with a larger network of university groups and have access to the expertise sitting there. And we are really having, in the past months, a very intense communication I didn't expect. And that tells me something, that there is a need to interact, that also FPR partners are accepted as really discovery or research clinical partners in that respect. One part of Summit is genetic research, as I mentioned. And what is the reason for that work package? Twofold. We want to find genetic variants, giving us an idea which gene, which polymorphism is susceptibility marker for the development of diabetic complications. So we have a measure for the individual risk. And that goes in the direction of personalized medicine. We can make a prognosis of a patient's diabetic complication. We can diagnose that patient on the basis of the genetic variant. And of course, we can also optimize the therapy for that individual patient. On top of that, it does not only help the individual patient, it gives us new insight into the research of type 2 diabetic complications. It gives us probably a handle to find new therapies, new modalities in the future with the help of the genetic variants for the individual patients. To give you an idea what we have done so far, we have gathered about close to 10,000 or even more numbers of biosamples for patients with type 1 diabetes and type 2 diabetes, which come out of 40 different cohorts in Europe, all over Europe. And this is really, I think, the gold nugget for a summit, that we have already now access to this large number of biosamples. This gives us the chance to really phenotype and make a very focused and clear definition of the phenotypes we are looking for, and to search in these databases and biobanks.